As we can see, there are approaches which can improve outcomes and decrease costs for patients with pediatric asthma, but the question remains, how do we pay for these kinds of interventions? Next, I'm pleased to introduce Dr. Darshak Sanghavi, who is formerly with the Brookings Institution and now is Director of Population Health at the Center for Medicare and Medicaid Innovation.
Thanks, Steve. Appreciate it. Can y'all hear me okay? So it seems like when we talk about asthma, one of the things I've taken away here is that asthma is a chronic disease, but as a chronic disease, the treatments for it are fairly straightforward. Why don't we send people to children's houses, exterminate the cockroaches that are leading them to have the asthma exacerbations? The inhalers are actually hard to use. You have to use a spacer. You're supposed to shake it an appropriate amount of time. It's actually not so easy, and yet the fix is pretty simple. It's education, having somebody go to your house to teach you how to use an inhaler. Or you can even say, well, when you actually start to feel sick, when you feel like you're actually having trouble breathing, why do you have to go to an emergency room? Why don't we have an easy way to access care so that they tell you what to do at home? You can avoid going to the ER. You don't need to leave your family at the Grand Canyon. You can actually enjoy your life. We know what to do. And what you've just heard about is a little bit about, well, what some programs are doing in innovative ways to get that care to people where they need it, in ways that actually save money. So one of the things I would want to know is, why isn't everybody doing this? It makes a lot of sense. And I think I'd like to quote what Paul Batalden has said, which is that every system is designed to get exactly the result it gets. In other words, most people aren't doing this. Why is it? And that's what I want to talk about, and then explore some of the things that we at the Center for Medicare and Medicaid Innovation and others are doing to try to make these incentives line up a little better. In 2010 was a passage of the Affordable Care Act, which in many fundamental ways was about getting health insurance for people that didn't have it. It improved access to care. But equally important is a series of innovations that are baked into that legislation that will actually change the delivery of care as well. And where is that problem? It's very simple to any of you who have hired a contractor for your house. I had this experience 10 years ago. And how does that work? Everything they do, they get paid extra, right? They don't hang up your kitchen cabinets on time? That's great. That's a couple more days of work, right? You pay for every time they feel like they need to install another window in your house. You're going to get a house with a lot of windows. Now, I'm a doctor. You've heard from a lot of doctors, but we're also people. We all respond to financial incentives. And when you get paid to do more and more and more, and nobody holds you accountable for quality, what happens? You do more and more and more and don't hold yourself accountable. And that's true not only individual level, on the system level as well. And so what we're talking about is, how do we make that better? And the term for that is fee-for-service medicine. But what it's really about is paying for more and more and more and not accounting or holding people accountable for quality. How do we make that better? And I'm going to talk a little bit about some of the strategies that are out there to do that ideally could be more and more applied to the treatment of pediatric asthma, but in fundamental ways should reshape the way we think about healthcare funding, financing, and delivery more broadly. The first is this thing called an ACO. And I remember a couple years ago, I was like, what is an ACO? Yeah, I don't know. So let's sort of take a minute and just explain what this is. Because as we said, what it is before you had an intensive care unit, you have a hospital, you have an emergency room. Not only that, you have primary care, the pharmacy, everybody works differently. Everybody gets paid differently. So if I work in an emergency room and every time somebody goes in, it's essentially a cash machine. I love when people come to the ER. I'm going to put up signs that say, our wait's only 2 minutes, come to my ER, right? People do that all the time. Why is that? When you show up in an ER, why don't they just call your primary care doctor and say, you know, Johnny's here to see us today. He probably just ran out of his inhaler. Do you mind if I just call in a prescription and we won't charge him for that ER visit? Makes a lot of sense. Nobody's ever going to do that. An ACO structure is different. It says, let's put everything together. You are going to have a combined group right here. And then at the end of the year, we're going to add up all the money that they charge and compare that to a target. So suddenly all those incentives are aligned. If they go to the emergency room, that's going to cost a lot of money. That's not good. you're going to want to actually have that child go and get that prescription refilled. In a way, what you do is then you hold that global target in mind. And at the end of the year, you say, well, okay, let's compare that to the target. Did you save money overall? And if you did, tell you what, you're going to get that to take home as a bonus. This is the basic concept of the accountable care organization. There's many forms and flavors of it that are quite complicated. However, the bottom line is this, is that early studies at least seem to show, and just this week, the Pioneer ACOs at the Innovation Center showed we had remarkable savings on the orders of tens of millions of dollars at various centers across the country. This is one way of getting off that treadmill. What's another way? So I just talked about this fee-for-service system, right? Every time you do something, you get paid more. Everybody makes a lot of money. This is why doctors drive nice cars. It's why health systems make tons and tons of money. Again, they're doing not because they're bad people, it's because what the system incentivizes you to do. But what if we did it a little bit differently? What if for an asthmatic child, when they first hit your system, and they had pretty bad asthma, as you've heard about, we said, tell you what, we're going to pay you a lump sum up front. We're not going to micromanage you, even though we're the government. We're going to let you figure that out. You figure out how are you going to, you can go to their house, do that extermination, send a community health worker to their house, make sure they're using their asthma medication appropriately. When they call your clinic, pick up the phone and call them back. Have services 24 hours. You figure that out. And you know what? We think that that's actually going to be great because that's going to lead to an emergency visit not happening. It's going to lead to savings in that way. And at the end of the year, because you got that money up front, you can keep the difference. Again, this is a different way of aligning those incentives. And the benefit of a bundle is that you may not have to get all the hospitals in your area together. This is a smaller and simpler way to get where you want to be. Heard about ACOs and bundles? Talk about this other concept, something called the patient-centered medical home. Sounds great, right? What is it exactly? Because I remember, again, we've done a bad job of explaining this. You know, I actually worked at a health center. We had a medical home. I didn't even know what it was. But the concept makes a lot of sense. It's very simple. You have a complicated patient. You have a patient with asthma. Here's what we're going to do. What you need is you need to kind of get out of this treadmill of having these 10-minute visits where you don't have time to talk to your patients, to understand what's going on at school, in the home. Take that extra time to say, well, how are you using that inhaler? Show me how you're doing it. What's that copay you're paying anyway? How often are you getting sick? What kind of housing do you? That takes time. It takes 10 to 15 minutes is all you get budgeted. Instead, we'll do this. If you have one of those patients in your clinic, we'll give you a bonus every month. We call that a per Benny per month or per member per month. It can be $5, $10, but that adds up. And so you can say, you know what? For all of our asthmatic patients, we actually want them to come to our clinic. Because you know what? We're going to use that money. And we're not going to use that to line our pockets. We're going to use that to hire somebody. We're going to use it to get those services. We're going to use that per member per month, put that together, and figure out what are the services they need. It's the same way of redirecting money from that typical fee-for-service stream into services that actually give you much higher value and higher quality. Basic concepts. Now, how do we get from here to there? There's a couple ways you can do it. You can sort of spring it on the system as a whole. You know, just impose it. People don't like that. They like to be incremental. That's okay. Again, we're the government. We can be incremental. We live incremental. All right? So that's what we're going to do. So this is what the Innovation Center does, is we move those experiments along. As we speak, there are accountable care organizations across the country. There are bundle payment pilots happening across the country. There are medical home demonstration projects happening across the country. So I think this is a time for great optimism and innovation within healthcare. I'm particularly optimistic because I have to be, given what we do. But I think that at the end of the day, what do we all want? We want people to have a higher quality of life. We want these kids to be able to go to school. We want them to enjoy and be normal so they can play on those basketball teams, baseball teams, and actually not be seen as those who simply have chronic diseases. And I say that not only as a pediatrician myself, somebody with the government, but also as somebody as a child who had asthma. Thank you very much.